Okay, thank you very much. Kind of giving me a quick workout today. 3 lectures in 2 hours. Anyways, we're going to talk about what does the literature say about adverse effects of blood transfusion. I think it's better if you go over here so I can look at you. The risks of transfusion have been well described in the literature, common from common issues such as fever, urticaria. Trolley is actually the most common cause of mortality following transfusion, hemolytic reactions, infections, all the way to HIV, yes. Other transmissible microbial agents and diseases include various viruses in sub-Saharan Africa, West Nile virus, malaria, toxoplasmosis, and so on. Transfusion-related immunomodulation was first described by Opels in 1973, where they noted via serendipity that renal allograft survival was improved in patients undergoing transfusion. And then subsequently, a number of other studies showed improved graft survival rates in transfused patients. Transfusion-related immunomodulation is based upon results in decreased T cell proliferation, NK cell proliferation, and an increase in suppressor T cell-mediated lympholysis, and increased serum neopterin. Yes. It's well known that transfusion is an independent predictor of SIRS related to a transfusion, and transfusion is also an independent predictor of ARDS and mortality. Numerous articles and literature substantiating that. What about transfusions and cancer recurrence? A classic paper by Gant et al. In Lancet suggested a link between transfusion and tumor recurrence, and subsequently Landers et al. Suggested that that transfusion recurrence relationship is not explained by other variables in the literature. Yet there are studies failing to show significance, but still evidence of a higher recurrence rate of cancer among patients who underwent transfusion. There are animal studies that support this clinical relationship via downregulation of the immune system. Transfusion is associated with increased post-op infections in many scenarios, including trauma, colon resection, coronary artery bypass, orthopedic surgery, as well as hysterectomy. Transfusion and ventilator-associated pneumonia. A transfusion is an independent risk factor for VAP after trauma with an odds ratio of between 3 and 4. And transfusion is an independent risk factor for VAP in critically ill patients with an odds ratio of 1.89, and is a dose-response relationship, which I'll show you in subsequent study. Here's nosocomial infection rates in critically ill patients in an article published in Critical Care Medicine. In a study of over almost 2,000 patients, those patients that underwent transfusion had a significantly higher risk of nosocomial infections compared to those that did not. And in terms of the correlation with infection in a dose-dependent manner, as you can see, as the number of transfusions increased, there was a dose-dependent increased incidence of infection in those patients who underwent transfusions. In terms of transfusion and ARDS, again, chance of ARDS in those patients who underwent as high as over 10 units of transfusion, clearly over 50%, approaching 60% of patients developed ARDS with a greater increase in blood transfusion. This was a meta-analysis performed by Merrick and Corin in Critical Care Medicine a few years ago, showing the relationship between transfusion and ARDS. I think you can clearly see that the preponderance of the evidence suggests a very close concordance between transfusion frequency and the increased risk of ARDS. What about transfusion-related acute lung injury? In terms of transfusion is the leading cause of acute lung injury. It occurs in 1 in 5,000 transfusions of RBCs, 1 in 2,000 of plasma-containing components, fresh frozen plasma and platelets is seen, with a mortality of about 6%. So very important to keep in mind when you reach for another unit of blood, the risk of acute lung injury. In terms of the epidemiology of multiple organ failure, classic papers cited thousands and thousands of times by Angela Sawaya from our group in Denver, showing that the risk factors of development of multiple organ failure increased tremendously depending upon the injury severity score and the risk of transfusion. In terms of transfusions and multiple organ failure, my colleague Fred Moore from Denver published this paper a number of years ago showing with each increment of blood transfusion, the risk of multiple organ failure increased tremendously. What about critically ill patients in general, non-trauma patients, all patients critically ill? Again, transfused patients versus non-transfused patients, tremendous increase in mortality based upon those patients that receive transfusion. Transfused versus non-transfusion patients, the logarithmic analysis showing that in those patients that receive transfusion versus non-transfused and log rank analysis, mortality significantly increased in those patients receiving transfusion. And this is a meta-analysis in another paper by Merrick and Corwin in Critical Care Medicine, looking at all comers, trauma, general surgery, orthopedic surgery, acute care surgery, and patients in ICU. And I think the evidence is clear and very abounding about the risk of transfusion and death in all comers. This is the question of stored blood and PMNs. We know that as blood is stored over time, from initial to upwards of 6 weeks of storage, there is priming of the PMN oxidase system by the plasma in the packed red blood cells, resulting in superperoxide anion production and less effectiveness in multiple areas of the blood transfusion. This is basically the apoptic index showing that with increased days of storage in control versus increased stored blood, the apoptic index decreases significantly. So what about the benefits of transfusion in terms of this survey? After seeing all of these incredible risks of transfusion, I think we'd all reach the conclusion that blood is very, very bad. And we have to really, really think carefully about our use of blood in transfusion. Clearly, the bottom line is oxygen carrying capacity and the use of blood as an effective means for resuscitating our patients very carefully. The classic manuscript was the transfusion requirements in critical care cooperative study, which was a multi-center prospective randomized study of 838 patients in 25 centers. These were patients who had greater than 24 hours ICU stay. A conservative transfusion was considered a hemoglobin around 9 within 72 hours, and they were volume resuscitated or normal bulimic, and the restrictive group were maintained to a hemoglobin of 7 to 9. These were patients with a median Apache score of 20.8, and the liberal maintained 10 to 12. So what were the results of that study? In patients with heart disease, the restrictive strategy should be considered the approach of choice. And Haber said that most hemodynamically stable, critically ill patients can safely receive a transfusion to a hemoglobin of 7 range, and possibly the exception being unstable patients with coronary ischemic syndrome. This is in a general critical care group. This was the results of those studies in terms of units transfused, liberal versus restrictive, mean hemoglobin in the restrictive avoiding transfusion. And you can see that the ICU mortality was no different. The 30-day mortality was borderline different in the liberal versus restrictive group. Again, beginning to approach statistical significance by using a restrictive strategy, and the MOD score was significantly reduced in the restrictive strategy versus the liberal strategy, all of course indicating that we can reduce multiple organ failure and mortality using a restrictive strategy. Ventilator outcomes in the Haber study showed no difference in terms of length of ventilation, ventilator-free days, or successful intubation in patients who were maintained on a restrictive transfusion strategy. And in terms of patients with ischemic heart disease, again, no significant difference. So I think that this evidence, together with our risks of transfusion that we've shown, clearly support the use of a restrictive transfusion strategy in a critically ill group of patients. So the efficacy of transfusion really needs to be based upon our ability to transfuse to increase oxygen delivery and tissue oxygen saturation. Animal studies suggest that oxygen delivery is optimal with a hemoglobin of 10. However, our clinical studies that I've just shown you have shown that hemodynamic and oxygen transport variables before and after transfusion in critically ill patients have no improvement following transfusion in terms of oxygen delivery. This is a study by Klein et al., which is frequently quoted, published in Lancet in 2007, showing the changes in cardiac output in the first slide in various, in man versus various animal models, in oxygen delivery in B, and in C is cardiac output changes, and D, oxygen delivery, indicating exhaustion of compensatory mechanisms after a short period of time. So transfusion of aged packed cells results in decreased tissue oxygenation. So we clearly need to look at our age of our packed red cells that we are transfused and the level of tissue oxygenation that we can accomplish. So in summary, I think the key point is that we need to deliver oxygen to the tissues. Heart rate and blood pressure are surrogates of monitoring only. Interestingly, yesterday, I had an article that crossed my desk for review showing that use of our current PICO and monitoring, arterial waveform monitoring mechanisms may be the most effective way for monitoring oxygen delivery to the tissues by seeing a reduction in arterial waveform analysis as being an effective way of assessing resuscitation strategy. We should follow base deficit, lactate, and tissue oxygen saturation as endpoints, and resuscitate our patients with permissive hypotension and monitoring our classic monitoring methods. If we're not meeting our goal, we need to look at our oxygen delivery and cardiac output and be very judicious in our use of crystalloids if we are restricting our transfusion criteria as well. Again, these are all important areas for future research as we try to identify what our optimal methods of transfusion are. Thank you very much.